talk about coiling of traumatic pseudoaneurysm, a case presentation. Stephen Ahmed, around? So we'll move. I skipped Abdullah. Mohamed Ashaf. Okay, Abdullah. Okay. Okay. So our next speaker will be Dr. Abdullah Mohamed Ashraf. Okay. Dr. Mohamed Ashraf talking about emerging therapies in pediatric vascular disorders.
Hello, everyone. Hoping you are all good, and thanks for your precious time. Emerging therapies in pediatric vascular disorder. Introduction to pediatric disorder. Vascular disorder in children encompass a wide range of conditions affecting arteries, veins, and lymphatic vessels. These can be congenital or acquired. Vascular disorder in children can be life-threatening if not recognized and treated promptly. Common pediatric vascular disorder, vasculopathies, traumatic vascular injuries. Congenital vascular malformation as arteriovenous malformation, lymphatic malformation, hemangiomas, vascular tumors as infantile hemangiomas, Kaposiform hemangioendotheliomas, thrombotic disorder as deep venous thrombosis, pulmonary embolism, arthritis, line purpura, traumatic vascular injuries, either be iatrogenic or penetrating or blunt or penetrating trauma. Emergencies in pediatric vascular disorder can be hemorrhagic and high output cardiac failure emergency, which can be like ruptured arteriovenous malformation or vascular tumor. Clinical presentation of these conditions as sudden or severe bleeding, high output cardiac failure as tachycardia, bounding pulses, hepatomegaly, respiratory distress, Kasabach mirrored phenomena, which is a consumptive coagulopathy, thrombocytopenia, low fibrinogen, and elevated D-dimer, seen in Kaposiform hemangioendothelioma or tufted angioma. Emergency management by immediate resuscitation with fluid bolus, backed RBCs in severe anemia with platelet transfusion if there is less than 50,000 per microliter, cryoprecipitate and fibrinogen if hypofibrinogenemia. Pharmacological control by propranolol, sirolimus, and vincristine. Interventional radiology in emergency procedure as transarterial embolization with coils or glue, surgical ligation if interventional radiology is unavailable. The second type of hemorrhagic and high output cardiac failure emergency will be massive hemangioma bleeding with common sites in liver and the airway with management by propranolol, intubation if airway compromise, and the emergency embolization if uncontrolled bleed. Acute limb ischemia causes thrombosis, embolism, or trauma, clinical presentation, pain, pallor, pulselessness, paresthesia, paralysis, and cold limb. Emergency management, unfractionated heparin with bolus 75 to 100 unit per kg, thrombolysis, catheter direct tissue plasmination activator, mechanical thrombectomy, Numera indigo system for large vessels clots, with surgical options as fasciotomy if compartment syndrome, bypass graft, rare in kids, only if reversible ischemia, Pulmonary embolism in children, risk factor, central lines, nephrotic syndrome, inherited thrombophilia, symptoms, sudden dyspnea, pleuritic chest pain, hypoxia, syncope, diagnosis, CT, pulmonary angio, echo, D-dimer. Emergency management, first stabilization of the patient by oxygen and intubation in severe hypoxia, IV fluid for right ventricle dysfunction, anticoagulant with low molecular weight heparin, unfractionated drip if hemodynamically unstable, or advanced therapies with systemic tissue plasminogen activator 0.5 milligram per kg over 2 hours if massive pulmonary embolism with shock catheter direct thrombolysis with lower dose tissue plasminogen activator, reduced bleeding risk, IVC filter, rare and only if recurrent pulmonary embolism with contraindication to anticoagulant. Acute stroke symptoms and causes, as we discussed later, emergency management, immediate brain imaging by MRI and differential weight index, non-contrast CT, or hyperacute treatment if less than 4.5 hours. Mechanical thrombectomy with IV tissue plasminogen activator 0.9 milligram per kg with maximum dose 90 milligram, which is controversial in kids with limited data. Anticoagulant and antiplatelet, low molecular weight heparin, unfractionated heparin, and aspirin. Critical emergency scenarios and management. First, Kasabach merit phenomena with life-threatening bleeding. Clinical presentation will be Kaposiform hemangioma or tufted angioma with severe thrombocytopenia less than 30,000 per microliter with BTK and ecchymosis with consumptive coagulopathy. Hypovolemic shock due to bleeding, as in the photo. The emergency management will be resuscitation by platelet transfusion, cryoprecipitate and packed RBCs, pharmacotherapy by sirolimus and vincristine, interventional radiology with embolization. The second case, arteriovenous malformation and heart failure. Neonate with lower limb arteriovenous malformation developed tachycardia, cardiac failure treated with staged embolization. Acute stroke or arterial ischemic stroke, clinical presentation, sudden hemiparesis, facial drop, aphasia, myoma disease, dissection, or cardioembolic causes, emergency management, first immediate MRI or CT, diffusion weighted MRI, which is a gold standard. Second step, hyperacute treatment with mechanical thrombectomy. Secondary prevention with aspirin, as in the photo. Psychological impact. Chronic vascular anomalies impact self-esteem and mental health. Psychological support and counseling are important. Challenges in management, diagnostic complexity, risk of recurrence, side effects of emerging therapies. Summary table, critical scenarios and decay section. Kaposiform phenomena with bleeding, sirolimus, platelet, embolization. Acute limb ischemia will be heparin, tissue plasminogen activator, thrombectomy, massive pulmonary embolism, low molecular weight heparin, catheter, thrombocytopenia, acute stroke with aspirin, neonatal aortic thrombus, unfractionated heparin, tissue plasminogen activator, surgery. Key takeaways: early interventions, saves limbs and lives, multidisciplinary care, hematology, IR, and ICU is crucial. New therapies, sirolimus, and thrombectomy improve outcomes in pediatric vascular emergency, time equal tissue. Thank you.
Thank you very much, Dr. Mohammed, sticking with time frame. Next